Broadcast is now starting. All attendees are in listen-only mode.
Well, welcome fellow members of the Musculoskeletal Tumor Society. Tonight, I have the honor of introducing our first MSTS webinar. The Education Committee, as shown here from 2019-2020, really assembled a great group of 6 educational webinars for this year. These will be a great opportunity for us as MSTS members, not only to get together, but to hear some really up-to-date or latest info on our array of interesting topics. I would personally like to thank Stryker, without whose exclusive support, we would not have been able to develop this webinar series. This is just a view of the webinars for the next, for the rest of the year, essentially the next 6 webinars. And today I have the opportunity to introduce our first webinar, which is on a particularly pertinent topic, COVID and its impact on not only on cancer patients, but its impact on ourselves as orthopedic surgeons. We have 3 great speakers: Susan Bukata, who's the Vice Chair at UCLA Department of Orthopedic Surgery; Victor Mulanovich, who's a Professor in Infectious Disease at MD Anderson Cancer Center and the leader of our COVID response team; and Michael Parks, who's an Associate Attending Physician at Hospital for Special Surgery. So I'd like this time to welcome all our speakers and also to thank them for spending this time with us. I believe first up, we have Dr. Mulanovich.
Thank you for the invitation and for the honor to speak with you. I'm going to start with no disclosures, and we will discuss the following topics. First, I thought I would show you where these decisions of how many days you have to wait for somebody to be cleared or for somebody that was exposed to be infected come from. A lot of the questions I get from colleagues that need to give chemotherapy, radiation, or operate on a patient are based on my patient was exposed at that time, or my patient had a positive test here or there, and when can I treat him? So the recommendations from the CDC have been changing, and rather than showing you the guidelines which you can easily reach, I will show you some of the data where they came from. So what is the difference between samples, yield, what is how long is the virus detected, how long is it infectious, and then new concepts that we're starting to learn how to deal with, such as what is a recurrent infection, is there a reinfection, and then the consequences real world in medical care, in cancer care. And I'll speak a little bit about the experience at MD Anderson and some information on surgery in COVID-19. So first off, the coronavirus RT-PCR, the test that we commonly get, we used to get, it can be from upper respiratory samples or from sputum or lower respiratory samples. The most common are the nasopharyngeal swab, the throat swab, and they tend to be positive from a few days before symptom onset, and for the following 7 days, that's when the amount of virus in the secretions peaks, and then it steadily declines. The amount of virus gradually declines over the following 7 days. Studies comparing nose and throat samples have been inconsistent on telling us which one is better. So I think different institutions choose which one to use. And sputum samples is important, and BAL. So lower respiratory tract samples tend to peak on the after 2 weeks, and they may stay positive for even longer time. So it's a different interpretation when you get one of those. Disease severity may affect the amount of virus. So there are reports that claim that the disease is more severe. You have a much higher viral load. And if somebody is going to get sicker, the viral load will go up, and if they're improving, the viral load will go down. So, how long is the virus detectable, and what does that mean? There are studies that have shown that the virus can be detected from. So, first of all, the definition is you need at least 2 or 3, depending on the study, consecutive negative tests to say that the virus that you have lost the viral load. So based on that, multiple studies, up to 66 studies, have shown that the median is 2 weeks, 14 days for upper respiratory samples, and a little longer for lower respiratory, 15.5 days. But there has been a wide range, and in fact, the longest duration reported has been 83 days. And in our center, we have had patients that have been positive for 4 months. So the time is different. The average of 14 days, and this is why in many centers it is heavily discouraged to repeat studies to ascertain negativity because we don't know what that means, and it can be much longer than we expect. Disease severity and duration of positivity or age and duration of positivity have been studied, and the association is not clear. Some studies have shown that the sicker patients, the older patients, remain positive for longer, and some have not. Immunocompromised patients seem to be or maybe positive for longer. Of symptoms, pre-symptomatic is when you catch them before development of symptoms. And how long are these patients positive? So asymptomatic patients, the median is 6 or 7 days into good studies, but the range is up to 3 weeks. Pre-symptomatic patients may shed the virus longer because they have an asymptomatic period and then they have a symptomatic period, and it's double that, it's 12 days. And they may start shedding usually 1 to 2 days before symptom onset. How long does a patient remain infectious? It's a very important question. And I'll show you the data where the recommendations of the CDC come from, but I think this is a moving target. So there was a nursing home study where they found asymptomatic, pre-symptomatic, and symptomatic patients. The patients that were positive then were tested with cultures. And cultures were positive from even 6 days before up to 2 weeks after the onset of symptoms. There are 2 studies that show that after 8 days, no cultures were found positive. And this day 8 in these 2 studies lend strength to the recommendation of 10 days after onset of symptoms as being a relatively safe time to consider that the patient is no longer contagious. And it's very important to consider all these studies. The majority of patients that have participated have been relatively healthy, not immunocompromised patients. Now, in the real world, so about epidemiological modeling, meaning not looking at infectiousness by cultures, but by actually patients getting infected. There was a large study with 100 index cases where they picked 2,700 close contacts, and they found 22 secondary cases. those cases where there was none of the contact was infected if their first exposure was more than 5 days before symptom onset or 5 days after symptom onset. So, and in the pre-symptomatic time, they all got infected in the 2 to 3 days before symptom onset, and after 5 days there were there was nobody that was infected. Now, modeling showed that a large proportion of transmission occurred in the pre-symptomatic time, and you probably have heard of many patients or friends who will tell you that they attend a reunion, and then the next day after the reunion, somebody is symptomatic, and they get tested, and then everybody that assisted or many people that assisted become sick. So the pre-symptomatic transmission is quite important. And the incubation time, the mean incubation time, so if you were exposed, it's 5 days, but it can last up to 10 days. So all that data is from patients that are in majority healthy. As time goes by, we are finding new manifestations of the virus and a series of other problems. And we are talking about reinfections, repositive, recurrence. So we'll talk about these terms and see what's behind them. So the big first concern was patients that are now called repositives, patients that after having positive tests, they have at least 2 negative tests, and then for some reason they get tested again and they are positive again. And this was a big concern some time ago. These authors reviewed 82 reports and case series comprising 1,300 patients. Some of them were still symptomatic or febrile. Only 4 of these 1,300 died later on. The authors also presented 9 cases that they had seen, and they did viral cultures on those patients that had positive after 2 negatives, and they were all negative. And the explanation they came up with is that these patients had prolonged shedding, and what happens is that not every test is positive, so they have intermittent positivity, but they assume that the majority of these patients are not contagious and are gradually recovering. So when you hear about repositive, it doesn't mean that the disease came back. It means that the patient has intermittent shedding. And this is one of the reasons, again, where we shouldn't be retesting frequently. Now, reinfection is a topic that has come in the last few weeks. There is now numerous case reports. First of all, the rationale, coronaviruses in general are well known to reinfect people, but usually after 6 to 12 months. So the immunity wanes, or if you have a very mild infection, it's not a very strong immune response, so you can get reinfected. So 6 to 12 months means that now that the pandemic has been going on for less than a year, that we might start seeing cases of reinfection. What's interesting is that in the last bullet point, these authors reviewed 13 case reports of reinfection, and the time where they occurred was between 4 and 13 weeks, the ones they found on the reports. So much faster. Now, 9 of those 13 had mild symptoms the first time and mild symptoms the second time. 1 had severe symptoms and then severe symptoms again. And then 3 had mild symptoms the first time and moderate to severe the second time, which is very concerning. So how do you know somebody is reinfected? You have to be able to isolate the virus and do genomic sequencing and demonstrate that the virus had diverged phylogenetically sometime before. The one cannot be, they're not the same virus or not very closely related. So we are seeing more and more of these cases, and it is concerning that either with the vaccine or with a primary infection, some patients may have a secondary infection and maybe sooner than we thought. Now, to keep this in perspective, there are millions of cases of coronavirus, and there are maybe less than 2,000 reports of reinfection. So how common this is, how frequent this is still to be known. We have to know. Time will tell if with time more people get reinfected or not. So another couple of terms, and these are things that we have seen in heavily immunocompromised patients at MD Anderson too. One is reactivation. This is a patient that has a proven infection. They are mildly symptomatic, or they have some symptoms, they recover, they never shake it off, and after a month or 2 months, all of a sudden they come in with worse symptoms. So they have multiple positives, they never shake off the infection, and it becomes more severe later on. We have treated a couple of patients with lymphoma. One of them had treatment the last time more than a year before, and they kept coming back with symptoms. It was back when we had this very strict criteria for treatment. They were not hypoxemic, and after a month, one of them came hypoxemic, and we finally treated him, and he did fine after that. So that's the other one is persistent infection. These are infections that waxes and wanes. They come and go. I have seen 2 patients with CAR T cell therapy that were infected after CAR T cells. As you know, CD19 CAR T cells impair your production of antibodies, and these patients got severe COVID, were treated aggressively, improved, and then developed severe COVID again within 2 weeks. While they were in the hospital, so they did not have a chance to get reinfected. These are patients that they cannot mount an immune response on their own, so they might, until the immune system improves, they can get the infection, or they can get severely infected again. And how much of this is the virus versus the immune response that the virus generates, the autoimmune response is to be seen. So moving on to, and you're aware that one of the problems that we've had with our patients have been avoidance of medical care. There was a well-known survey in June that showed 41% of our patients of respondents avoided medical care, and 12% of those were actually emergency or urgent care. And patients with insurance, patients that were more educated, and also minorities and unpaid caregivers were some of the highest risk. And people who were afraid because they have underlying conditions. A survey in Texas last month showed 36% of respondents also had avoided, they or somebody in the household had avoided medical care because of COVID, and more on the highly educated with higher income. So a lot of this is obviously fear, not only lack of access. Regarding mortality, the numbers have been all over the place. This is a review of 52 studies. On the right, you can see they found a pooled mortality rate between the 52 studies of 26%. Some studies showed up to 50%, and some showed very low mortality. But 26% was the pooled mortality of these 52 studies with thousands of patients. So the authors recommended that cancer should be considered an independent risk factor for mortality in patients with COVID-19. At MD Anderson, we have, in a way, been somewhat fortunate. We haven't been overwhelmed with patients, but we've had so far 640 cases up to last week. 238 were admitted. Almost half of them were hematology patients. Now we're dealing with a lot of readmissions, almost 20%. 26% of the patients died, which is 4% of the total, and 11% of the ones that were hospitalized, so that they had more severe disease. And it was 50-50 almost hematologic patients versus solid tumors. because of the previous concepts I showed you of persistent infection and reinfection, we have been modifying our guidelines, and our patients with active COVID go to the COVID unit, and to come out of the floor to a regular floor, or to be hospitalized in a regular floor, the patient has to be at least, if they are hematologic malignancy patients, at least 30 days from the first positive test, and if they are solid tumors, 20 days. And these goalposts have been slowly moving. And still, we're not sure that we're covering all patients. So after 30 days, if the patient has symptoms or is still on oxygen, infectious disease has to evaluate, look at the imaging, and decide where the patient can move out of the COVID floor or not. So we're leaving some wiggle room to keep some of those patients, because none of the tests that we have can assure us that those patients are not yet contagious. And the ones that we had the most problem with have been the patients that the hematologic malignancy post stem cell transplant, leukemia, or CAR T cells with significant symptoms. So going to surgery and COVID-19, there was a large, the COVID Surge Collaborative had 1,100 patients that had surgery either 1 week after diagnosis of COVID or that got COVID up to 30 days after surgery. This is on many different countries and multiple hospitals, and they looked at mortality and pulmonary complications. Of course, 74% of the surgeries were emergency surgeries that could not be avoided, and they found a very large number. So patients with COVID had a high rate of postoperative complications, especially pulmonary, and this was associated with high mortality. So they recommended that the threshold for surgery in patients with COVID-19 should be higher, particularly in men over 70 years, because the rate of pulmonary complications and mortality was high. After this, they did a study where they had COVID-free pathways, meaning that either this is for cancer patients, and either cancer hospitals that were COVID-free, so they did not operate on COVID patients, or areas of the hospital that were completely isolated. They had to have inpatient ward, operating room, and ICU that were COVID-free. So no patient with COVID would get on those places. So if you can isolate part of your hospital for patients that don't have COVID, they showed that there was a significantly lower pulmonary complication rates and also less postoperative COVID infections. So this is an alternative, and it has been done in a very large multinational study. So time is short, so that's all I have. And I pass back to Susan or to Mike.
To Susan. So Dr. Bukata from UCLA is up next.
Okay.
Thank you very much, Dr. Mulanovich.
Oh, no, Dr. Parks is up next.
Okay.
Sorry.
Thank you, Val, and it's a pleasure to be here, and thank you guys for the invitation. Val asked me just to talk about my experience as a COVID patient, and I titled my talk An Unexpected Journey because as I thought about the implications of COVID, it seemed so far away, and I didn't think it would affect me, and little did I know that it would come to me firsthand. These are my disclosures, none of which are relevant to today's talk. So basically on Sunday, March 15th, I was at the weekend in Leaston, Long Island, and I thought that everything was normal. And I checked my email, and there was a call for the hospital, which is very unusual for a Sunday. And the call was all of the faculty for the orthoplasty service, and we were notified that the governor was going to shut our hospital down after Monday surgery. All elective surgery would be canceled. And I think I naively had thought this wouldn't happen because we're an orthopedic hospital and I didn't think we'd be taking care of COVID. And I think I underestimated the impact of the COVID pandemic. So on Monday, all of our elective cases were done. And I was notified about a patient who was an elderly nun who had had a total hip replacement a couple of weeks before. And it was done at the outside, and she dislocated 6 times in 2 weeks. And her doctor had told her just stay in bed for 3 months and she would be okay. So she was transferred in. I did an elective urgent revision on her, and she did well. And we kept her in the hospital because placement was an issue. After that, I left, and I left New York City and went to my weekend house where I isolated. And I have neighbors that are very good friends of mine, a couple that are my age with a 13-year-old, and we'd have dinner. But other than that, I saw no one. And I would go to the grocery store, and I saw people in masks, and I thought, well, they're really overblowing this. This is not a big deal. It's not going to affect us. My neighbor had a cough one day, and she was completely asymptomatic. And I drove her to 3 urgent care centers, none of which would see her or do a test because of the risk of transmission of COVID. Other than that, she was fine. And we continued to have dinner for about another week. Well, by March 26th, I developed a cough and a scratchy throat. And it was probably the worst cough I've ever had in my life, where if I had anything in my stomach, it wouldn't have lasted. And my symptoms continued to progress, and I became really, really tired. I mean, tired to the point where I couldn't walk across the room, and I had extreme chills. Now, what you'll notice about that's the week of the academy. And at the time, as the OREF president, we had all these calls. And I remember, if Christy Weber's on this call, there was a call that we had with the academy leadership. And I told Dick Kyle, who was the vice president at the time, that I wasn't thinking clearly or feeling well. And if in the middle of the call, I didn't feel well, that he should just talk. And I would just sit there silently because I realized that I was just getting sicker. But despite the fact that I was getting sicker, I kept telling myself, well, I'm a doctor and this is just a bad cold. And I've been at home by myself, only seeing my next door neighbors, and I don't have COVID. So I got a lot of over-the-counter meds, which my neighbors brought me, which did absolutely nothing for me. And I just remember I couldn't find a thermometer. There was no thermometer to be found anywhere. And I was freezing cold. My house is about 10 years old. And I did my builder's total hip. So I called him at night and asked him to send someone over to fix my furnace, because I was convinced that the furnace had gone out. I was just freezing and I couldn't get warm. And so the guy came over the next day, checked my furnace, and he looked at me and he said, doctor, your house is 80 degrees and your furnace works fine. And after charging me a bundle of money, I just thought, well, the furnace is broken and this is just not working. It still hadn't dawned on me that I was getting sicker by the hour. So I decided again to self-treat, and I have a steam shower. And I guess I'm kind of thick. I took a steam shower and I couldn't stay in there. I couldn't breathe after 2 minutes. And despite filling the shower up with eucalyptus, I was annoyed because I had bought this essential oil, which usually I treat, when I have an upper respiratory infection or congestion, I breathe the eucalyptus and I'm fine. I couldn't smell the eucalyptus, and it just didn't dawn on me. I just thought, this is horrible. And I went to sleep. The next day, when I woke up, I realized that I didn't have any energy, and I probably should come back to the city because I didn't want to be out in Eastern Long Island and get sick and go to that small hospital. And it took me from making that decision at 7 in the morning until about 11 in the morning just to get myself together. I didn't have anything to pack, but I remember I was just kind of confused. And friends were offering to take me back to the city, and I said, no, I'll drive myself, which was really a bad decision because I almost had 2 accidents on the way. But I did make it back. Interestingly, on the way, I noticed I was kind of hungry. I hadn't eaten in a day, and I stopped to get something to eat, a hamburger. And I took a bite, and I remember feeling this warm sensation in my mouth. I knew I had food in my mouth, and I could taste or smell absolutely nothing. So I threw away all the food and drove back to the city, coughing all the way. When I got home, I was exhausted. And my internist is a very good friend of mine. And I called him and I explained to him the progression of my symptoms. And he said absolutely nothing while I talked. And I told him that I just wanted to go to sleep and that I needed to get an inhaler so that I could breathe. And then he started screaming at me at the top of my voice, not to go to sleep, at his voice, not to go to sleep, but to go to the ER immediately. And I remember thinking, he's really exaggerating, I'm fine. And I went just because he told me to go. So I got to the ER, and I remember telling the nurse, you know, I might have COVID, but I think I have a cold. And I sat down, she took my vital signs, my temp was 103. My blood pressure was 145 over 105. I'm not that hypertensive. And then when my labs, my BUN, creatinine were all very elevated. And I also remember when she asked me what medicines I took. I take 2 antihypertensives, Norvasc and Benicar. I could not call the names. I just remember being confused and I could not think of the names. And I told her she was gonna have to look in Epic because I couldn't remember the names of the 2 medicines that I took. And it was just very crazy. So at that time, they really didn't have any treatment. They kind of watched me, they had an IV in. My SAT was 93 or 94, and I had a long talk with the ER attending, and she said, there's nothing they're gonna do for you. They took a COVID test, but she said, we're really short on tests. We don't have tests. We're not gonna run it, and we're not gonna admit you. We're gonna send you home because there's nothing that we would do for you. Your SAT's not decreasing, and as long as you're stable, we'll be okay. So they literally handed me discharge papers, took out an IV that they didn't give any fluid in, and said, you can go home. And I stood up, and I remember becoming just really confused, and I heard something hit the floor, and the next thing I knew, there were a bunch of people standing over me, trying to put a cervical collar on me and put me on a stretcher because I passed out. And I think I was, for a while, an uncooperative patient because I remember, the only thing I remember telling them was, my neck doesn't hurt, I don't have pain, don't put on a cervical collar. She said, well, you might have broken your knee. I said, my knee is not broken, I could stand up. I don't have an orthopedic problem, I can't breathe. And I said, I'm not gonna get a head CT and all these things that they were gonna order, but I can't breathe. So because of my syncopal episode, they admitted me to the hospital. At that time, this was early in the pandemic, there wasn't a lot known. So there was a lot in the media about remdesivir, hydrochloroquine, but I was not treated with any of those medications because there was no documented efficacy of any treatment. So basically, even though I was hospitalized, it was really more of observation, and my temperature remained high for 2 days. And I think the most unpleasant thing I've experienced in life was an ice bath to bring my temperature down. But observation, O2 sat monitoring, and Tylenol. And I was in for about 3 days, and on the 4th day, I was discharged. Against conventional wisdom, the night before I went home, I had a temperature spike of 103, but because there was nothing they were gonna do, they sent me home anyway. In the short term, I recovered 2 weeks of isolation. I continued to have fever for about 4 days after discharge. And ultimately, as part of my recovery, I started from a non-productive cough to a productive cough, but I was extremely fatigued. By June, I had my first night back on call. So it's 8 weeks later, and there was a patient who needed an IND and a lot of skin loss. So I had a plastic surgeon with me. And I remember the hospital had new protocols where everyone had to wear an N95 mask and a regular mask. And I put on an N95 mask, and even in June, I could not breathe. I couldn't catch my breath. And I couldn't stand to do the case, so I sat, and the plastic surgeon did the IND. So even 8 weeks later, I was still extremely fatigued and not ready to do any operative cases. Over the next few weeks, I continued to get stronger, but it was August before I completely recovered. Until then, I had modest fatigue, modest shortness of breath, and even now, I still can't tolerate an N95. But I think that I'm back recovered, and I feel great and fortunate to have recovered from this misadventure. Just as an epilogue, the patient that I operated on, she did very well after her surgery while she was in the hospital. But because she was a nun, she was sent to a post-operative care center where there was an outbreak of COVID. And in early June, she died from COVID, along with about 10 or 12 other nuns and priests. And it just marks just how severe and how much our patients are impacted by this disease. Thanks, and I hope that everybody stays healthy and doesn't get to share my adventure with COVID.
Thank you so much, Dr. Parks, for sharing that. I know it was a scary time because I actually remember when you were driving back from East Hampton and you were like, I have COVID, I have COVID. And I was like, you don't have COVID, you don't have COVID. And then I whispered to Isabella, oh my God, he totally has COVID. So it's great to see you back, you know, running 2 rooms and operating. I know it was a really long haul, and I'm glad you made it through. So up next, we have Susan Bukata. She's a professor and vice chair of orthopedics at UCLA, and she's going to talk to us about managing the COVID patient, or the COVID orthopedic oncology patient. Thanks so much, Susan.
Thank you. And I obviously can't spell with my title slide, so I apologize about that. I have no conflicts that are associated specifically with this talk. So I am the vice chair of operations for the orthopedic hospital at UCLA. And so very early on, we saw what was going on in China. We saw what was going on in Washington. And knowing that we have a lot of patients who go back and forth with Asia, we started to plan ahead. What do we need to do? And we were quite fortunate in that our chief of labs went to the chief of pathology in mid-January and said, hey, we're going to need to be able to test for this in large volume. I think I'm going to need to develop my own test. At that point, the CDC was telling us we had to send everything to Atlanta. And fortunately, the chief of pathology basically said, go ahead. It's a $10,000 fine if they slap us later. It's a lot worse if we don't do it and we really need it. So we were extremely fortunate because we got a head start. We did not have the experiences that New York had early on, and were able to see low volumes in the beginning. However, we did suffer from a lot of the same issues that people did around the country in terms of PPE, in terms of not knowing what to do, and really having to take information on a week-by-week basis and make decisions about what could happen in the hospital, who could get taken care of, what do we need to do about admissions, how do we protect our staff, how do we protect our patients, and making sure that the essential patients could actually be done along the way. So a lot of what I want to talk about is, now that we have some of that knowledge, and we have some of the knowledge that Victor showed us in his talk earlier in this, how do we prepare for wave number 2 or wave number 3, knowing that it's going to be a while until we get to those vaccines? So the number one thing we know we have to do is we have to keep the providers safe. If we don't have safety for the providers, we cannot take care of anyone. So we need to make sure we have enough PPE to deal with COVID-free patients as well as COVID-positive patients. For us in the University of California, there's now a warehouse in Northern California and Southern California. We actually were very fortunate. We had a domestic supplier. So as everybody was scrambling, it was harder for us to get materials that normally would come to us because they were being redeployed around the country. We came together, all 6 campuses, and with Stanford and some of the other major hospitals, including Kaiser in California, and we are now our own independent importers of PPE, so that we have stuff stocked in the warehouse, and we still get reports every week how many days ahead we are. I'm 4 months out on gowns and most masks. I still am only 45 days out on N95 masks because that's all that we can get. So then we had to look at doing things like, could we reuse them? What are safe ways to do it? Having people on the main campus test things and looking what other people were doing in terms of ultraviolet light and what was possible for them, and making sure it was safe for our providers. Also, looking at having alternative housing for providers if they are sick, if they have gotten exposed and need to stay separated from their families until we figure out if their COVID test was positive or not positive, or if there's a family member in their household that's sick and we need to keep the person separated in order to keep them safe for work. So we scrambled and we got some alternative housing, apartments near the hospital, and the ability to check on people if they were symptomatic, having nurses there who can check on people to make sure that they were okay and not getting sicker without someone looking at them. Also, as Victor mentioned, we decided to have sections of the hospital that were isolated from COVID positive patients. It's the reverse thinking about hospital beds and facilities. So normally you isolate the sick people. Here, knowing that we had the potential to be like New York and really have most of the hospital be full of patients who were COVID positive. Unfortunately for us, that never happened. We did the reverse, and we started to pick an area of the hospital that we could isolate, that we would maintain as COVID-free. Providers, nurses, patients, and be able to take care of our essential patients in that way. So we needed to prioritize those units for the patients at greatest need to continue care, like oncology. So we literally rearranged our entire hospital. So if you see in this picture here, there's a tower that you can see there. So that was our COVID-free tower, and attached to it right up until the portico, that back end is operating rooms. So we could isolate that whole section for patients as well as for operating and intensive care unit beds, keeping that completely separate. And because there's two hallways when you enter the hospital, you go right or you go left. The building to the left is also completely capable with operating rooms, ICU beds, and patient beds. We decided that that is how we were going to divide patients. Trying to get enough testing and getting so we could turn it over as quickly as possible became a top priority. So everybody that came in for surgery, everybody that came into the hospital would get a COVID test. And we gradually had to ramp up being able to turn that around within about 6 to 8 hours to make sure that we were able to figure out who might be positive and who might not be positive. And we had a little holding area in the beginning when you came in with isolated rooms, so that until we got a test, we presumed you were positive until you cleared. And then we would send you to what was the appropriate tower. So we treated everybody with all the PPE and everything necessary. We probably don't have to go to as extremes in terms of getting people in, because we can turn over tests much faster. We do now have a limited supply of high degree PCR rapid tests, not the same as the Abbott test, which isn't quite as accurate, but things that actually will run a PCR. We can only run 2 tests at a time, and we're actually limited to 37 tests a day across the entire medical center. So those have been prioritized for what we call red line traumas, for transplants, as well as for emergencies within oncology patients, so that we can make sure that whoever is most at risk, we can test as quickly as possible. And then we're trying to get other things turning over. We do about 8,500 tests a day. We are going to be able to do almost 100,000 tests a day when we get the campus labs online. Hopefully at some point we'll have the students back. But again, different tests, nasopharyngeal tests we use with high priority for the patients in the hospital, because that has had the highest degree of accuracy, and it will actually be combined with a flu test starting November 1st. Automatically, that's just the way it's going to be run. The on-campus test, where we will be doing some pooled testing, ways to look at units as we bring people back to work. Those will be able to see if we run much faster and larger volume, but we will know who put their sample into a specific box. If something is positive in that box, we then can go back with the more refined test and be able to check that specific group with the PCR test. So there's ways that we're evolving in order to try to make it safer for our patients and safer for our workforce. We do need particularly to make the oncology patients feel safe. I'm sure, just like all of you, we are now seeing the people who waited since March to get that lump looked at. We are seeing some of the biggest sarcomas we've seen in a very long time. We are seeing young people with breast cancers where they saw the lump in February or March and were afraid to come in, and now it's a very large lump. We're seeing patients with symptoms that have really gone quite significant before they come in with a diagnosis. Myeloma with fractures, tumor all over the place. So we really want the message to get out to the patients as well as the primary care doctors that if you're worried about a cancer diagnosis, we need to get you looked at right away. We want to reassure patients we have these protected wards. We have PPE to protect them. We let them see us cleaning. We let the patients, we even if you put the alcohol on the way into the room, we wash in the room. On the way out, you want to wash. You want to have even the people who are helping to clean the rooms. We let the patients see that going on so they are comfortable with the fact of what we're doing and trying to keep it as safe as possible for them. We have to limit visitors, use remote communications for patients to family and friends. It's healthy for them to communicate with their support group, to communicate with their family. So we now have iPads in every room, and we use telemedicine for some consultant check-ins and for help for us when we need specific issues with patients so that we can limit traffic, particularly in the COVID-free wards. And testing. Every admitted patient preoperatively with 2 days prior for every patient that's going to the operating room, judicious use of the rapid test, and then staff surveillance. Currently, we're mostly using questionnaires, but now we're hoping when we're able to do those big runs with the pooled boxes that we're going to have periodic testing probably every 2 weeks for everybody. And fortunately, it won't be as bad because it's a midterm and it's swab. So you just can swab sort of the center part of your nose, drop it in your tube, and put your tube in your box. One more. Okay. Again, getting the message out to the patients, don't ignore the signs of cancer. Primary care doctors, when they're doing their video visits, as they talk to patients, if they hear something like that, really encouraging them and telling them, look, we need to look into this. We can make this safe for you. But if we ignore signs of cancer, this can go out of control where we can no longer save you from your cancer. Even during that COVID surge, we need to let patients understand that that diagnosis ignore, it can be more likely to kill you than getting COVID. We also, from a surgical standpoint, need to prioritize oncology cases during operative slowdowns. So coming with a plan. Now that we've all had these slowdowns one time before, we need to plan that this is going to happen to us again. Nothing would make me happier than if we never have to deploy this plan, but you as a provider need to think about what will you do in this situation. When the hospital is full with COVID positive patients, the barrier is hospital beds, not OR access, which is the reverse of what we usually have. We need to think about what can we do as outpatient or short stay. We also have to have a system in place for case selection and timing within the hospital, recognizing that surgeries for oncology are often timed around radiation and chemo. So if you have people on a clock, stick to that clock. Make sure that the group that organizes both your beds as well as your operating room are aware people need to fall in this window, so that if cases are restricted, again, they are already on a high priority list, particularly to be in the COVID-free section of the hospital. Also, getting us to really think about changes in our paradigms. We need to do inpatient care when it is the safest for the patient, and possibly even at that point have a dedicated family member stay in the hospital with the patient the entire time, essentially on isolation in the room with the patient, so that they will be well trained in care for post-discharge for that patient every day with the nurses. Outpatient chemotherapy with video check-ins. We're slowly seeing more and more people move to outpatient chemo if we can make it possible for them. Also having to help to train family members and caregivers how they can help. A few times we've done surgery up front and then all of the chemotherapy. If it's possible to do that, we can do it in a safe manner, especially if it's large or we potentially are worried that it's going to go to an amputation. If the chemotherapy and the radiation is not going to change our ultimate therapy, then sometimes we're doing the surgery up front and continuing the entire chemo on the back end of it so that we can keep that patient first through the operative procedure and then isolated in the chemotherapy wards. Looking at some radiation protocols that shorten the time frame, including some of these 5-day protocols that are starting to be looked at multiple institutions, doubling up on some metastatic disease. So patients are getting 2 treatments in a day. They're here for a whole week and just treated morning and evening. And planning for home care post-op. Doing thinking that we wouldn't necessarily have to do because the discharge manager would take care of it from the floor. Having the right supplies available to the patient. It is almost impossible to get a hospital bed in Southern California delivered to a home right now. There just are none to be found. Getting early delivery of materials before discharge so we know they're there. Coming up with creative solutions for care gaps. Teaching family members to help with PT. Having PT be on video visit with a family coach that's with them and making sure to help the patient through the things that can be done at home. Doing video visits and video physical therapy and video checks, both with medicine as well as infectious disease or medical oncology, whoever we really need. Trying to arrange home health access, knowing your community. In some communities, that's easier than others. Also with some insurances, it's easier than others. So knowing that up front is much much more helpful. Also, we recognized there were some patients, we just couldn't get home health for them. So we wound up just, if their length of stay was normally 3 days, maybe their length of stay was 14 days because I couldn't send them on home health care and I couldn't get them into a skilled nursing facility. So that is something we just had to accept as a hospital as a part of our care for those patients. Again, frequent video check-ins with the patients and using our nurses, care extenders, and mid-level providers to help with these check-ins so we can keep track. So I think the biggest message I could say is make a plan now. If you come to the table with a plan, particularly in your institutions, you will have a lot more control about what happens with your patients as well as, excuse me, as well as what happens with your cases during that time frame. No COVID, just pollen. So that's it. I think if we have any questions, I think all three of us are happy to take any questions that people may have.
I think we have two questions from Dr. Tyler. The first one is to Michael. Dr. Parks, do you think the confusion was the result of hypoxia or secondary to COVID involvement in the neurologic system?
Oh, I think so. I think that one of the things that I didn't mention, I was delirious and I didn't realize it. And I think my internist astutely did. When I called him, he actually listened to me talk. And he said he was so concerned, he almost drove to pick me up and bring me to the hospital. And he called me every 20 minutes until I was admitted to my room, but I have no recollection of talking to him. So I think that it was just delirium from sickness. And I'm not sure if hypoxia played a role, but I was clearly delirious.
Great, thank you. And Susan, Wakenda asked, what percentage of your visits right now are telehealth?
So we actually kept a fairly high volume of in-person visits for the oncology patients. So it depends, it differs by provider. Overall, across the orthopedic oncology unit, for us, it's only about 20% right now. In terms of the orthopedics department, we're still doing about 20 to 25%. We actually are seeing a higher volume of patients than we saw pre-COVID. And I think some of it is because some of the disease that got deferred is so significantly worse that the community providers that were doing some of the early work are just handing it right into the university right now.
Yeah, that's great. I think at Anderson, we're seeing a huge dichotomy of patients, though. We're having a huge influx of pediatrics, but also a really large influx of patients 70 and older. Like, I kind of miss my 30-year-old healthy patient or 50-year-old with the sarcoma. We're really getting lots of young kids and lots of old kids. There was a message from Dr. Morris, our president, who said, thank you all. That was excellent. And I have to agree. I think each of your talks were just wonderful. And I want to thank you personally, but also on the behalf of the MSTS. Are there any other questions, Carrie or Deborah?
No, just another thank you from Dr. Vitti and thanking everyone, appreciating sharing their perspectives and experience.
Awesome. So I guess we'll close out our first MSTS webinar. I think we are off to a good start. Carrie and Deborah will actually send out the list and the dates of our remaining webinars so everybody can put them on the calendar. I think we've assembled a really interesting array and a diverse group of speakers, orthopedic oncologists and non-orthopedic oncologists, really to help us get through this new year of COVID. I'm saying year because I'm tired of being stuck in Texas. So get through the rest of year of COVID. And I want to say everyone good night and thank you so much for joining us.
Thanks, Val.
Thank you.
Thank you, everyone.
Hey.